Let's move on to psych. All right. If a patient gets treated with an SSRI for depression, but they become manic due to undiagnosed bipolar, what's your next best step? Well, you should immediately discontinue the SSRI. Don't begin treating the bipolar with lithium or another agent without first discontinuing the SSRI. And at this point, it's like nitty-gritty semantics of what they're testing you on. Obviously, if this happens, you know it's underlying bipolar disease, but then it's like, well, what's the better answer? And you want to go with immediately discontinue the SSRI before you treat them with lithium. Number 4, here's your acute mania treatment protocol. You want to have an immediate acting agent, such as an antipsychotic like risperidone, and that's for patients that have escalating agitation or psychosis. However, you want to maintain them with either lithium or valproate. And so lithium, remember, it can affect your kidneys, so you want to avoid that in patients that are CKD. And valproate, you want to avoid that in patients that have end-stage liver disease. So if it's a patient with cirrhosis, you would more often use lithium. If it's a patient with end-stage renal disease on dialysis, you would more often use valproate. If they have severe mania, you can actually combine their antipsychotic with the lithium or valproate pretty much right away. And so remember, you want to have that immediate acting agent for very, very severe cases. If they have insomnia or they're very agitated, a benzodiazepine can also be used. Number 5, so if you have a patient with lithium use and they take a thiazide diuretic or an ACE inhibitor or an NSAID, and they now present with tremors or altered mental status and their lithium level is elevated above 1.5, what do you do? Well, if the lithium is 1.5 to 4, you give them IV fluids to basically flush it out and recheck your lithium hours every 4 hours. You can also add polyethylene glycol for bowel decontamination. That's your Miralax. And if the lithium is greater than 4 or it's greater than 2.5 with symptoms of renal failure, you want to dialyze them. So usually this is a patient with a super high lithium level, maybe it's 5, 6. The next best step is to dialyze them, hemodialysis. And an important thing to note for those of you that want to get those few extra physio points, lithium can cause a type 1 renal tubular acidosis. And something that's helpful is that lithium has low interaction with amlodipine or furosemide. It has high interaction with thiazides. So that's very good clues to help you out for lithium toxicity. And you want to watch out for the interaction between lithium and tetracycline or lithium and metronidazole, because those can also cause an increase in lithium levels. And on the other hand, a patient that maybe starts getting more and more symptoms of mania could be somebody that's on lithium, but they just started either mannitol or amiloride or theophylline, because those can lower lithium levels. So it's helpful to know the medications that can raise your lithium levels and ones that can also lower your lithium levels. All right, bipolar symptoms refractory to lithium or valproate. What's the next best step? Well, you want to add an antipsychotic. That'll be tested. Number 7, a patient gets an antipsychotic, but they have the following side effects. This is incredibly high yield for all of your shelves, as well as step 2 and step 3. If it's acute dystonia, you want to do benztropine or diphenhydramine. If they get akathisia, you want to give them a B, B, or a B. So a beta blocker, a benzo, or benztropine. If they have Parkinsonism, you want to give them benztropine or amantadine. And then tardive dyskinesia, you want to do valbenazine or deutetrabenazine. All right, those, if you don't know them, pause the video, rewind it, and test yourself on acute dystonia, akathisia, Parkinsonism, and tardive dyskinesia. So for the tardive dyskinesia, I look for the ones that have ben, so valbenazine and deutetrabenazine. For Parkinsonism, you got to memorize the benztropine with the amantadine. But remember, benztropine is also used for akathisia or acute dystonia. So if you see basically benztropine as an answer choice and you have any of these type of side effects, it's probably correct. So it works for acute dystonia, akathisia, and Parkinsonism, but also you want to know the other treatments that work as well. Remember, akathisia you can treat with all the Bs, the benztropine, the benzo, or the beta blocker. All right, number 8, if a patient is having an acute onset of psychotic or paranoid symptoms, it is not appropriate to gently confront the patient's irrational beliefs. Even though the word gently is in there, it's still wrong. I got tricked on this before because it seemed like a reasonable answer choice. The correct answer was maintain interpersonal distance and avoid challenging a patient's beliefs. And this is for somebody that has an acute onset of psychosis. All right, so basically just keep your distance and allow them to work through their episode. All right, number 9, here's a banger list of serotonin syndrome high yields. This is tested off and on, so you really need to know this. All right, so you need at least 10 days after MAOI discontinuation and 2 to 5 weeks after discontinuation of an SSRI to pass to avoid serotonin syndrome if you're switching to another serotonergic medication. And the reason I share this is most people only know the SSRI discontinuation phase because that's what's asked in UWorld. It's different for MAOIs. You want to give them at least 10 days. All right, and if I was writing a USMLE question on serotonin syndrome, how would I write it? Well, I'd mention that a patient had Parkinson's and depression, which are highly associated with each other, and they recently began taking phenelzine for depression and has new onset myoclonus. And that's easily confused with a tremor that you would see in Parkinson's for many test takers. And the patient may also have some intermittent episodes of confusion, which can easily be written off as a side effect of Parkinson's dementia. So, plus, patients with Parkinson's often are taking selegiline already to prevent dopamine breakdown. And so, those two medications together, you can be at risk for serotonin syndrome. So, look for somebody that has the myoclonus, that's a huge clue. And look for new onset confusion when they start a new serotonergic medication. That should clue you into serotonin syndrome. And don't forget, this is something that I've not seen tested otherwise, but NBME 13 tests lithium as a cause of serotonin syndrome. I've never seen it in any other kind of USMLE board resource, including AMBOSS, the UWorld, but it's here, so make sure you guys know it. And the highest yield tip, I want you to be able to differentiate from neuroleptic malignant syndrome, NMS, due to the presence or the absence of hyperreflexia in clonus. If there's clonus, think serotonin syndrome. If the patient has rigid muscles with no clonus, think NMS. And this is usually seen with antipsychotics or antiemetic use. So antipsychotics can also cause akathisia, which is the inability to sit still. And if that presents in the question stem, your next best step is to lower the dose of the antipsychotic. If that fails, then start a beta blocker, such as propranolol. Remember, we said akathisia you can treat with the BBBs. The treatment of serotonin syndrome is going to be cyproheptadine, which is a serotonin receptor antagonist. And my mnemonic here, which has helped me so many times, is C for clonus, C for cyproheptadine as the next best step. If the temperature is greater than 106 degrees Fahrenheit, your next best step is sedate, paralyze, and intubate the patient. They have very, very severe serotonin syndrome. The treatment for neuroleptic malignant syndrome is a benzodiazepine plus dantrolene plus bromocriptine to restore the dopaminergic tone. And remember, dantrolene works for both NMS and malignant hyperthermia, which is seen with anesthetics like halothane or succinylcholine, because it blocks the calcium release from the ryanodine receptors. You need to know ryanodine receptors is associated with dantrolene. You need to know that dantrolene works for NMS and malignant hyperthermia. So I remember the two that have the letter M in them. So NMS and malignant hyperthermia works with dantrolene. And you need to remember cyproheptadine, C for clonus, C for cyproheptadine, which you see with serotonin syndrome. So that'll get you a lot of points. Make sure that you know that little section. All right. Let's go through a differential of often forgotten causes of acute onset psychosis in children or adolescents. Well, urea cycle disorders is tested, acute intermittent porphyria can be tested, Wilson disease, lupus, and one that's a little bit more rare but I've seen show up from time to time is anti-NMDA receptor encephalitis. And then cannabis, stimulant, or bath salt, which are also written as synthetic canthinones on the test, they can also cause acute onset psychosis. If a patient is using any illicit substances, they must have a prolonged abstinence with episodes of continued psychosis to be able to actually diagnose a psychotic disorder. Otherwise, it's attributed to the illicit substance. Do not select a primary psychotic disorder if they have any illicit substances in their system during the episodes of psychosis. That's a good test-taking tip for you. And whether psychosis is substance-induced or a primary psychotic disorder, the treatment is still going to be antipsychotic medications to stabilize them.